Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. This is a 38-year-old man with a history of stage 3 mediastinal poor risk non-seminomatous germ cell tumor. He was diagnosed in January of 2020. Got 4 cycles of BEP and whole brain radiotherapy twice, initially for a new brain met and then again for further recurrence. And so the questions for this case are around next recommended systemic treatment and about re-irradiation for his CNS metastases. This patient presented with fatigue and fullness in the neck, ECOG performance status of 1. At the time did not have prior medical history. Was a former smoker, quit 15 years ago, social alcohol, but no drug use. Family history, grandmother with an unknown cancer type, but no other urologic or other malignancies. His oncologic history dates back to January of 2020. He had a lab workup showing elevated tumor markers and a scrotal ultrasound with just microlithiasis. He had a biopsy of a supraclavicular node, which I think is probably how he presented, and was consistent with malignant germ cell tumor, predominantly embryonal carcinoma. CT staging revealed multiple non-calcified pulmonary nodules, as well as mediastinal adenopathy. MRI of the brain and spine at the time did not have evidence of disease, and also had retrocoral and retroperitoneal adenopathy. In March, he completed 4 cycles of bleomycin etoposide and cisplatin, which would be standard for his advanced stage non-seminomatous germ cell tumor. Repeat staging done after chemotherapy showed decreased pulmonary nodules, marked decrease of his diffuse lymphadenopathy, as well as normalization of tumor markers. In July of that year, CTs had further decrease in pulmonary nodules and retroperitoneal lymphadenopathy. And maybe before we go on to when he unfortunately had further progression, so we know in non-seminomatous germ cell tumors, the dogma is to resect residual abnormalities. Something that we face in our tumor board all the time is somebody who has abnormalities, but they're kind of close to the end of chemo, and we say, well, maybe we should wait a little bit and see how they do. And I guess I'll ask Dr. Abel first in terms of timing of surgical intervention in a post-chemotherapy non-sem patient. How quickly do you go in? How do you decide when to go in? What's your sort of approach to timing?
Yeah, so usually about, I would say, a month after you guys would complete chemotherapy, we would, if we're going to do like a post-chemotherapy RPL&D, that's usually the time that we'd be looking at. Again, some patients, if they have more lab abnormalities or malnutrition or any other hiccups during chemotherapy, then we wait a little bit longer. It's it's somebody with a larger mass, it's usually a little bit more black and white. When you have just small amounts of residual, then sometimes we're more willing to wait a little longer.
Okay, so really based on size and how pathologic are the residual abnormalities? Is that fair to say?
I think that's right. I think in general, we would want to go in as soon as we think is safe. And a lot of these patients are really young, and so a lot of them bounce back really quickly. But there's certainly some patients that we would slow things down a little bit.
And if the patient has residual pulmonary nodules and say just retroperitoneal nodes, do you do everything at once? Is there a sequence? Is there a preferred sequence, or does it depend?
Yeah, I think that's a great question. So I think it's sometimes we do, if there's just a few pulmonary nodules and you can do just a really easy wedge resection or something. I think it's the same thing with liver. If you can either wedge out an area of liver, it's not as often, but sometimes we would do that, or ablate it at the same time. If there's extensive disease in the lungs or anywhere else, then we would usually stage the procedures.
Yeah, okay, thank you. So this, so that was July of last year when the patient was responding about 3 or 4 months after completion of chemo. Unfortunately, a month later, he started to have elevation of tumor markers and neurologic symptoms, including right-sided weakness, confusion, and headaches. Has an MRI with multiple brain mets. We'll see some images in a little bit, and completed whole brain radiation in 30 gray and 10 fractions. So, Dr. Shah, do you want to talk about, and I know we haven't seen the images yet, but again, in my world with kidney cancer, we avoid whole brain like the plague. Because I think it turns people's brains to mush, and especially a young person with hopefully 50 years of life expectancy. I assume there's a role for SBRT here as well, or is it thought about differently?
No, I mean, so it's a great question. So, when I started training, whole brain was standard in many cases, and we really limited to use stereotactic radiosurgery or SBRT or Gamma Knife, depending on what platform you have. That's evolved a lot. So it used to be even 5-10 years ago, 1 to 3 lesions, we might do Gamma Knife or stereotactic radiosurgery. Now there's data saying even up to 7, 10. We see continued level 1 evidence showing that we can use this. So absolutely, I think whole brain is decreasing in its utilization, number one. Reasons we would consider whole brain is if you end up with a scan that has, for example, innumerable metastases or has leptomeningeal disease. Those are cases where we may consider whole brain. And even there's been some data saying in really advanced patients, symptomatic measures are actually comparable to whole brain radiation. So I agree, it's getting less and less. And those patients that need whole brain, there's a couple options also to decrease those side effects that you mentioned. Number one is the use of memantine, which has been studied on prospective studies and shown a decrease in neurocognitive side effects. And the other is in patients who have brain metastases outside of the hippocampi, is use what's called hippocampal sparing whole brain radiation. This has also been prospectively studied. So there are some options in those patients that need whole brain to also decrease those side effects.
Thank you. So now moving on, just a month later, gets an MRI, has decreased size of his treated lesions. Unfortunately, then 3 months later on his follow-up MRI has numerous new brain metastases with edema, but without midline shift, and gets repeat whole brain radiation. So Dr. Shah, I'm not sure that I've ever heard of repeat whole brain radiation. Can you help me?
Yeah, so it can be done. In my experience, we tend not to do as commonly when it's within a year of the previous whole brain radiation or even within 6 months. So whole brain radiation can be given more than once, but those neurocognitive side effects we talked about certainly can be amplified further by giving a second course of whole brain radiation. There are some rare situations where we give it, for example, symptomatic leptomeningeal disease when someone who's previously had whole brain, but in general, we tend not to give second courses of whole brain radiation if they have any possibility for stereotactic radiation and other options instead.
Okay. And so that was February. That must be February of this year. I think the year's wrong here. That's February of 2021 when he got repeat whole brain radiation. And then March has, fortunately, body imaging and ultrasound of the scrotum, which don't show progression. And so the plan is immediate systemic therapy. Let's move on. The next slide actually shows some of the MRI findings. And so Dr. Siegel, I'll ask you to take us through here and note some of the dates here. So February of this year in the bottom left was sort of the recurrence when he got repeat. So the other ones must have been prior, sort of in between whole brain radiations, if you will.
Well, we can see on the top two post-contrast MR images from September and from December, there's already been an increase in size of these brain lesions, and then a significant increase in both size and an additional lesion on the February 2021 study, with then marked response 1 month later.
Yeah, so I guess the good news is this patient is responding to radiation, albeit with quick recurrence in the brain, certainly never a good sign. And so let me ask Dr. Jakaki about sort of the role of systemic therapy. So this is clearly a multiply refractory CNS disease, but his body is stable. I'm not sure we know his markers, but let's assume that those are stable. Do you agree with starting systemic therapy in this patient?
I'm not really sure how systemic therapy will be beneficial in CNS disease at this point. If he had disease in the rest of the body, probably trying salvage tip might not be unreasonable with this 24-hour continuous paclitaxel and then ifosfamide cisplatin for the 5 days treatment. But I'm not sure, again, what will be the benefit in the brain.
Yeah, I'm not sure if, this is obviously an unfortunately unique patient. I'm not sure the data about systemic therapy and preventing CNS recurrence to your point, but I think there's sort of a certain desperation here to do something in somebody who's already had two bouts of whole brain. And then one of the next questions is really about if he has further CNS recurrence, God forbid. I mean, Dr. Shah, what possibly could we do? This patient's had 2 whole brain radiations at the doses that I think were on the previous slides.
Yeah, so I mean, he's gotten 58 grade plus a boost. I would probably not give a 3rd course of whole brain radiation. You've already probably reached or exceeded, in some cases, the normal tissue toxicities for things like the brain stem and potentially the optic apparatus, depending on how it was designed. If there was brain recurrence and it was limited, I would consider stereotactic radiosurgery if it was the only site of disease, in a sanctuary situation. But that would be it. I would not favor a 3rd course of whole brain radiation.
Thank you. So just to summarize, an unfortunate young man with sort of CNS recurrent and refractory germ cell tumor status post multiple irradiations. The recommendation is really against or cautiously against more radiation to the brain, depending on anatomy and some of the other features that we probably don't know about this case. And I think some ambiguity about the role of systemic treatment here. And I agree, I'm not quite sure, although I'd probably be tempted to do it just out of desperation. And we do tend to give TIP as our salvage regimen. And then I think, assuming you can gain CNS control, I think you need to start also thinking about the role of bone marrow transplant in this patient. But I think it's mostly around the questions are really mostly around the role of radiation. And again, this is a sort of unique biology for this unfortunate patient.
And I'm wondering if intrathecal chemotherapy has ever been studied or used, but I can't imagine how, intrathecal methotrexate or cytarabine would have been beneficial in that histology. I would assume that we are all confident that the metastasis is germ cell and not something else.
Yeah, I assume so. And I don't know any data about intrathecal chemotherapy for germ cell. It may exist, but I have no personal experience and I'm not aware of the data. But yeah, again, it's sort of that desperation to do something in the CNS for this patient, because that's clearly going to drive, the morbidity and such for this patient.